This is Daniel King, and you're listening to George Fox Talks Wellness. I am so excited to have our guest today. Today we have Dr. Dan Rhon. He's here today. He is a physical therapist and researcher. And just recently, he had an article that was published in the New England Journal of Medicine looking at physical therapy versus glucocorticoid injections for the osteoarthritis of the knee. And so we're really excited to have him here today. Just to start off, we're just going to start talking about osteoarthritis. And I just wanted to ask Dan if he can maybe share with us maybe some of the symptoms or maybe just overall general things about arthritis, especially around the knee, that might be helpful for some people who are listening this morning or today.
Yeah, well, first of all, thank you so much for inviting me here to share. I'm really excited to be here. So, osteoarthritis, it sounds a little scary, a little ominous, but the reality is that probably most of us will have some measure of osteoarthritis at some point in our life. It's as one colleague refers to it, it's somewhat like wrinkles on the inside. We see the signs of aging on the outside. Our skin gets a little bit older. Those are signs of just wear and tear and in time. And on the inside, we see the same thing too. In particular, the joint surfaces. So anywhere where two joints come together, if you think about, over the years, many days of life and activity, those things start to wear down a little bit. And in some people, in some situations, in some circumstances, that wear down might be come on a little bit faster than others. So the challenging piece about that is that a lot of people have this wear down and don't have, in fact, most people have this wear down and don't really have any pain or symptoms or problems. They're completely asymptomatic. So that makes it a bit of a challenge. So we identify that osteoarthritis is typically symptomatic osteoarthritis. We refer to as it causes symptoms. And so those symptoms are typically pain. You start getting a little bit of pain, usually maybe in the morning when you're a little bit stiffer. Stiffness is another thing. So if you notice, man, once I get up and it's hard to take those first few steps, but after my joints loosen up a little bit, I can actually move a little bit better. I feel a little bit better. But then that pain might get a little bit more severe. You might feel it as you're putting a little bit more load through the joint, like going up and down stairs or getting in and out of cars. So that leads obviously to a much bigger problem where a lot of individuals get to a point where they really can't do a lot of those things. And then what we call sort of end stage disease. And disease, I don't really like using the word disease because it makes it sound like you've caught something really bad.
Right.
But that's just the technical sort of term for it. Degenerative joint disease, knee osteoarthritis, those are all synonyms. And so many individuals go and end up having to get a knee replacement down the road. And so that's typically the symptoms is pain and swelling, probably in the, start to come on in the fourth, fifth, sixth decade of life. Usually you don't feel it before that unless you've had maybe a significant injury to your knee. So maybe if you've had an ACL injury in the past or you've torn your meniscus, have had surgery on your knee, then you're at higher risk for earlier onset of arthritis.
Yeah, getting ready for our time today and just being a physical therapist myself, I know there's like over 30 million people who actually have arthritis. So I think that this topic is really important for a lot of people to hear. And I liked how you were framing it about the wrinkles inside and that a lot of people are asymptomatic, meaning they don't have any pain at all, even though they may have some changes inside. And some people do. And, I think one of the interesting things is that people always think about the end of it, right? Like getting a surgery of some sort to try to fix it. But I loved your article because it gave us different things to think about, maybe prior to needing some type of surgery at the end of our time with the disease or the process. And I was hoping that maybe you could share with us a thing called clinical practice guidelines. Clinical practice guidelines are these guidelines that we are as caregivers or providers use to give the best, consult for what's going on with the patient. And maybe Dan could kind of talk about clinical practice guidelines around NEOA and what it said about it.
Yeah, sure. So clinical practice guidelines are usually put together by organizations that are considered to be authorities in the field. And so they consist of a panel, usually a multidisciplinary panel of experts that assesses the literature. So what is all the evidence that we have, the clinical trials, the systematic reviews, and they try to take all the treatments that are available and they organize them into categories of recommended treatments, not recommended treatments, or in many cases, we just don't have enough information to really say whether we recommend it or not. And so some of those organizations are the American College of Rheumatology, the Osteoarthritis Research Society International. They both have their own clinical practice guidelines, which are very similar. I work a lot within the Department of Defense. And so the Department of Defense and the VA typically partner together, the Veterans Affairs. And so they also have published clinical practice guidelines. And so they're guidelines to help direct care so that clinicians working in the hospitals, the goal is that in clinics that it's a guideline to help them deliver the best quality, the best evidence care out there and sort of funnel doctors and nurses and physical therapists and ancillary staff in the right direction in terms of what is recommended and what is not recommended. And so a lot of times reimbursement will also align with interventions that are recommended by clinical practice guidelines, or if you're providing something that isn't recommended or that is specifically recommended against, the ACR, the American College of Rheumatology, has several treatments that they recommend against, then that might influence reimbursement and payment models.
Yeah, and that's a great explanation of clinical practice guidelines. I love that. I wish we had time to maybe talk about the things that we shouldn't be doing, because that might be a fun podcast. But maybe just for the time's sake, we'll talk about maybe a few things that we should be doing. And it's funny, right? I love the title, physical therapy versus glucocorticoid injections, right? Almost like it's like going against, but sometimes you could do both, but maybe not. And I thought that was really an interesting tension just from thinking about it, because I think a lot of patients, they also think about what are the options that they have, right? Should they go to physical therapy or should they get an injection of their knee? And I think that was really what I loved about the paper, but I think it has a real clinical application. When we think about patients, when we think about providers, not just physical therapists, but also primary care providers who are thinking what should be the next step when someone comes in and says, hey, I got these symptoms. What should we be doing next? And so maybe you can kind of share with us, was physical therapy and injections part of the clinical practice guidelines that are out there for NEOA?
So that's a good question. And I think it's important because I'll tell you that when we, when we set out to put this together, and then when we were submitting this, a lot of the comments from the peer reviewers and the physicians reviewing this was, nobody only gets injection or PT, everybody gets both of these. And the thing is, our data and everything that we had looked up in the research shows otherwise. And injections are received by approximately 50% of patients getting with knee osteoarthritis in the 5 years, anytime in the 5 years before they have surgery, knee replacement surgery. And physical therapy occurs maybe 20% of the time. Even less for those that don't go on to have surgery. I think referral rates in one of the largest studies that we have with several million encounters, referral rates are as low as 5% from primary care settings to physical therapy. And orthopedic surgery settings are a little bit better, I think, at closer to 11%. And so they really aren't used very much at all they're underused. And so we wanted to really look at that and say, well, what is the reason for that? Maybe there's a patient preference, maybe there's a clinician preference. The guidelines specifically recommend, probably the core intervention that they all recommend is exercise therapy. And we can come back to that maybe a little bit later, because I think exercise therapy, exercise in general and activity seems a little counterintuitive to a lot of patients. And so the idea is my joint is breaking down and now you want me to exercise. And so that's always a challenge. And there's some pretty good research behind why that's a challenge and why a lot of patients are resistant to probably the intervention that is recommended as, the highest priority in all of the guidelines for patients with knee osteoarthritis.
Yeah, that's that. Go ahead, Dan.
No. I go for it.
Yeah. So I would say I would agree. I used to have my own practice, and I would hardly ever see anyone come in for knee osteoarthritis directly. It would be primarily, I would get it when it was a post-op for a total knee replacement or some type of surgical intervention. So I would agree with you. And I love the fact that we're looking at, this high level data to show, what kind of encounters that they have, that physical therapy was really only utilized at 20%, maybe at the max, and sometimes as low as 5%. And that injections were probably the thing that we were going to more. Again, looking at the evidence or the data, because you're right. I think a lot of people think that they're doing both, but sometimes when we are looking at our practice acts or the way we're practicing, I think it sometimes shows us something different. And I loved how you guys clearly did that. In this paper, is very clear to me that it was either physical therapy or injection, and that was the two groups that you had, and I loved how clear that was. Can you maybe share with us like what we did, what was presented for physical therapy, and what you would recommend in physical therapy if there were some physical therapists listening, or if we had patients listening, like what should happen in physical therapy?
Yeah, so the goal is exercise and movement is really the ultimate goal here, because as soon as you stop moving, this is why there's a lot of other secondary health effects that are associated with knee osteoarthritis. We know comorbidities, sleep-related, nutrition, your physical activity goes down, you start gaining a little bit of weight, you don't sleep as good, exercise and mental health, depression is correlated. And so when you stop moving because your knee hurts and so you want to stay off of your knee, it can lead to all of these secondary health effects. So we really, at the end of the day, we want to get people up and moving and not see, their knee pain as a hindrance and a barrier, because a lot of times it's more fear driven that it's going to get worse than it really is substantiation that it is going to get worse. And that keeps a lot of people from that. So when you come in to see physical therapy, we delivered a manual therapy approach, which we have shown to be effective in several different trials in the past. It's an approach that really focuses on movement. And so you get the joints moving. Sometimes the joints, there's physiological motions and then there's accessory motions, which is the way that your joint doesn't naturally move. And when you don't have a lot of activity, those areas can get a little bit stiff. And so the manual therapy almost helps them to exercise a little bit better. So it's not uncommon to manually get the joints moving. So we put our hands on the joints, the patellofemoral joint, the tibiofemoral joint, a couple different joints in the knees, try to get the ankles loosened up and moving well, some good stretching. And then all of that is so that they can then participate in the exercises that we have, which really focus on movement. And so that is a core component of the physical therapy program. But I would say that's a challenge. And so as primary care providers, as physical therapists, as anyone dealing with these patients, the biggest challenge we have is convincing patients that it's safe to do this. And there's a lot of evidence. There was a large Cochrane review that explored sort of these ideas in patients that were waiting for their knee replacement. And so they had all of these different barriers that prevented them from wanting to exercise. And if you think about it, these things are I mean, these are real concerns that we have to learn to be able to address, because if we can't get past these cognitive barriers of this is going to get worse, we can't really, we can tell the patient to exercise all they want, but then they're not going to go home and really do it. So there was another study in the clinical orthopedics and related research. It was really interesting. These patients were waiting to have surgery. So they had essentially, not had the success that they wanted with rehabilitation, but they were asked about this, and they identified. So the researchers identified all these different identity beliefs. So the patients all thought that their knee was bone on bone, they called it, and they believed that bone on bone was caused by wear and tear, and that loading the knee joint would further damage this vulnerable joint. So there's these consequence beliefs, these causal beliefs that their pain would deteriorate and get worse over time. So naturally, physical therapy and exercise are only going to increase the pain. They're not going to replace the lost knee cartilage. So the only thing that makes sense rationally is to have surgery, and so nothing else really makes sense. And that's because we don't have time always to sit down, especially in primary care. I know in the health system I work with, we don't have a lot of time to sit down and explain and dialogue and sit with the patient with these and challenge these beliefs about vulnerability. And so, it's not surprising that they don't see any other option other than getting a new joint as being able to address their symptoms and really ultimately fix the problem. And I struggle. I'm a physical therapist, and I do this research, and I struggle with my neighbors that are good friends that don't know what I do, like, family that, it doesn't matter. Like, I struggle. Like, I see these are people that know me, that trust me. And these are really just ingrained beliefs that make it really challenging. And so I think we've got to come up with ways to help change the narrative and help them understand, the potential that's there if they want to put the time and effort into this.
Yeah, such good things. And I'm thinking about the narrative and how we in healthcare can start helping with that, right? Because I agree with you completely that the wear and tear almost feels counterintuitive to actually do exercising or exercise in general. And I love how manual therapy is not just looked upon as something passive, but is something looked upon as active to get them prepared to move. And it is moving a joint and is moving a part of the body, like almost like stretching. And I think that putting your hands on a person too helps confirm that you're with them and that you're kind of helping with those obstacles versus just putting them on an exercise equipment, which may feel threatening to some of them, especially if they're believing that there's wear and tear in their joint versus someone examining them as well as moving the joint. Because I know that there's assessment that's happening while we are doing manual therapy with the patient. And I mean, how many times have we seen patients open up as we are doing manual therapy and continuing on that conversation about pain, stiffness, why it's swollen, and then even movement, like, is this going to hurt me and what's going to happen? So I think that manual therapy in this case is one of those things that actually decrease obstacles for them to start moving and feeling more confident in it. And I know that, this is a little off topic, but I kind of want to share or maybe ask you about this whole understanding of therapeutic alliance. I think that what you're talking about as these obstacles is kind of like these beliefs or identity. And I think one of the things that maybe we're recognizing that might be important is this therapeutic alliance or this trust that you have with a care provider. And I know that in the study, I don't think you guys studied that or looked at that, but is that something that you think is important as you're kind of going through a program? Is this trust between the client and then also the provider, especially when you think to yourself that there might be real damage that's in the knee?
Yeah, of course. I mean, sometimes the trust in the provider is one of the most important things. That therapeutic alliance, it's just a technical term for, when you go see a doctor or you go see a mechanic, I mean, you love the one that you feel like you make a connection with, that really understands you, that listens to you. They could almost not even know what they're talking about, but they just made you made a strong connection and you're drawn, you want to work with that individual. You feel like they care about you. So we, at the end of the day in medicine and across the board, we're trying to change behavior. And I think there's a psychology to behavior change. Information alone doesn't do that. We know that has very little to do with changing behavior. And so it's not only building trust, but it's engaging. Our communication skills are so important. It's engaging with patients in a way that it creates change. And so we're doing a lot of that. We have a study with health coaches and chronic pain, trying to implement these changes. And there's so much that comes down to the communication and how we talk with patients. And, how often do we just give them an exercise program? But really, so I use this analogy that we know already from the literature that the patient has to want to change. That's the first step, right? When you look at the stages of change, they have to say, I want to change. We never really assess a patient's willingness to change before we already tell them this is what you need to do. And I think that's one of the critical steps. My wife, who's a counselor, always says, you can't care more than the client does. They have to care. You can't care more than they do. And so we have to, just like if I'm building a house, I don't just start building the house because I want to know how much is it going to cost me. I need to sit down and say, all right, here's what it's going to cost. Am I ready to invest in this? Plan it out. It's a big decision. And I think we need to sit down sometimes with patients and say, I've got good news and I've got bad news. The good news is there's great potential to get better with this exercise program. Lots of people do. The bad news is potentially that this is going to take some work and this is what it's going to require. And so I just want to know, is this something that you are interested in? Do is this something of interest to you, realizing that this is the cost associated with it? And so have those discussions early, pitch that with the patient, talk about what it means, talk about their unique barriers. What would prevent you from doing these exercises? What does your work schedule look like? Figure out whether they even want to change. And maybe you might get to the point where you feel like, I can't not let them do this. But again, you can't care more than they do. Okay, well, I respect the fact that you maybe don't think this is right for you, but I just want you to think about these things. Maybe when you come back next time, they've thought about it. Keep trying to push towards that point where they're ready to make the change, and then you can take them on this journey. But behavior change is extremely challenging. And I mean, everyone believes that exercise is good for them. That's not a problem. Everyone believes that exercise has tremendous value. It's you get home, you have a busy day, then you're getting into bed and it's like, oh, I forgot to do my exercises today. I'll do them tomorrow. And then the same thing happens. There's always good intentions behind this. It's just the coming up with a plan so that you can actually change behavior. And this has to do with diet or going, exercising regularly. All of these things require planning. They don't just happen because we give somebody a handout and say, hey, do these exercises at home. So we got to spend a little bit more time, I think, helping these individuals make the changes, making sure that they want to change. But a therapeutic alliance is a really important piece of this to build their trust and then point them in the right direction.
Yeah, I like that a lot. And I like how you use that to talk about behavior change. And maybe then we can talk about the other intervention side, which is the injections, right? Because it wasn't just one injection that they were able to receive. They get to receive a few times because I think they saw the provider or the rheumatologist or the PM&R physician on, I think, 4th or 9th and 12th month or something like that, Dan. You can correct me if I'm wrong, but I know they were able to see them and they were able to get 3 injections at a time during those during the times that they saw the provider in total. So, maybe we can talk a little about that, about injections and maybe more specifically, just, when did they decide to do an injection and when did they not? And I know we're both not physicians, but you are a co-author of this paper. And so I just wanted to just maybe have the listeners make sure that they know that we're thinking about it from the other side as well, too.
Yeah, injections they can provide, this immediate pain relief. They're cheaper usually, just right there in the visit. and they're just easy. Like you can just get it right there in the visit. So, there are some benefits when you're making that decision. I just want to give a real quick overview of the trial because we've kind of talked about the couple little pieces there just to put everybody on the same page. But essentially, we randomized patients that came in for knee osteoarthritis. They were randomized to either go to physical therapy or to get a steroid injection. And then we would follow them for a year. So the physical therapy, they received roughly about 8 to 10 sessions. The injection was supposed to be one injection, but based on normal clinical practice, people can come back and get more injections. So we wanted to make it pragmatic, meaning that it sort of represents real world scenarios. So that's the other thing with physical therapy is patients might come back. We provided an opportunity for a booster. So, but what we mean by that is you come back and check in at 4 months and 9 months and, hey, how you doing? How are things going? Maybe they get 1 or 2 more sessions of PT if they wanted it. We look at their exercises, make sure they're doing them well. Nobody's forced to do any of these things. It's just offered. And the same thing with an injection. You check in with the physician 4 months later. Hey, how are things going? And they would, if the patient asked for it, that injection was great. I'd love to have another one. Then they would do that. And so that's how things happen in the real world. And we wanted to sort of mimic that. Well, over the course of the year, our primary outcome, which is a standardized measure that measures pain, function, and stiffness in the knee, showed a significantly better improvement in pain, stiffness, and function in patients that had received the physical therapy component intervention compared to those that had the steroid injection. Both had improvements, but the PT was substantially better. At the end of the year, 4 people in the injection arm had surgery. 3 of those had their knees replaced, and 1 had an arthroscopic procedure, and none of the patients in the physical therapy arm had received any surgery. And so when we go back and look at the interventions that people received, it seems, again, easy and to just get that injection, give me the injection, I'll feel better, I'll be on my way. But the fact is that the mean number of injections received was like 2.3 or maybe 2.7. So almost everyone ended up needing more than one injection. So it didn't provide long-term pain relief. They needed another injection. And I think about 19 individuals, maybe 20% of individuals ended up getting referred to physical therapy anyways. Maybe it was a little bit higher, but there was quite a few people that ended up going to physical therapy anyways. And so the idea is that maybe that short-term relief and pushing off PT, isn't a better investment. We just published in JAMA Network Open, I think last month, we did a cost effectiveness analysis because it's really important to then assess, okay, you get a little bit better with injection, you get quite a bit better with physical therapy. But, and again, you can't discount the fact that the PT sessions cost more, not just money, but I've got to come in, maybe I've got to find childcare, maybe I have to get out of work a few extra times. So we wanted to know the extra cost that was spent on the PT, is it really worth it? And so you do what are called these cost effectiveness analysis where, we use the healthcare economist and that really breaks down these willingness to pay models and the quality of life years that you get from the intervention. And so we found that with all these additional simulations, the primary one and all these multiple simulations, that getting PT, even though it was a little bit more expensive at the beginning, over the course of the year, because of how it reduced your, less people had surgeries, and, other people had additional injections and all that, it was a cost-effective intervention compared to steroid injection. So, I think it helps to think about the long-term picture and not just, hey, what is the benefit that I'm going to get right now? And so if I can put in a little bit of time and effort into PT, my quality of life might be quite a bit better at the end of this year compared to just getting the injection and not getting PT. So, injections, while they can provide some short-term pain relief, there's also recently been several studies that have been starting to challenge what we know about them. And, it's not that they're really dangerous, but maybe they're not as safe as we thought. And so there's some studies that show that they might actually increase the risk of getting a knee replacement. So in one large study published in the Journal of Bone and Joint Surgery, this large cohort, those that had an injection had a 9.4% greater increase in risk for having a knee replacement at the 9-year follow-up compared to those that didn't have an injection. The other thing is that a lot of physicians that push back on this, saying like everybody gets these together, it doesn't really make that much difference. The reason that we didn't, and they asked us why we didn't compare the two, like why not look at the additive value of why can't I do both? Right. And we're not saying you can't do both, but there are 2 trials that were published, one in JAMA Internal Medicine, I believe, and the other one in PLUS One or PLUS Medicine that looked at combining injection with exercise or injection with PT versus just exercise alone. And there was no better, the outcomes weren't any better or any different in the group that had an injection in addition to the exercise. So you have a little bit of risk, maybe you're degenerating the cartilage a little bit more, but it didn't actually add any greater pain relief or function compared to those that just had the injection the exercise without the injection. And so based on two studies, in high impact, high tier journals, it just doesn't seem, the evidence at least doesn't substantiate the practice of delivering both of those. So let's give you an injection and then you'll feel better and you'll be able to tolerate physical therapy. In our trial, at the short term, so at 4 weeks, which we consider the short term follow-up, the pain relief was identical in the group that had the injection versus the group that had the physical therapy. So there was no additional benefit or greater pain relief. Exercise is very, very powerful if done the right way to help reduce pain. And so I think we need to, to know that and not, belittle the effects that it can bring to the table.
That was a great summary, actually, of the paper, but also 2 different pathways that we're all hoping for the same results, which is decreased pain and decreased stiffness. And I just thought that you did such a great job summarizing that. I want to maybe ask a question that's about exercise. You made a statement that if we do the right kind of exercise, right? Because there's lots of different kinds. Yeah. And right. What it was in your trial? What was some of the exercises that you would recommend, or that was recommended for the patient who had arthritis? We know that manual therapy was something that they received, and then it sounds like I loved how you used the word pragmatic, meaning real day. Kind of what we do. But what was in general maybe some of the things that that was done in the script of how to do exercises with this patient?
Well, I would say the first thing is you want to promote physical activity with your patient. So, if they're going out walking, they've got, an elliptical machine, a bike. A bike is great. It increases a little bit more of your knee flexion. So that's all supplementary. In fact, I tell my patients, I almost try to make that be a bigger piece of this because, look, you're here in the clinic with me 45 minutes out of your maybe 3 times a week. You're not in here 99% of the time. You're not with me. So what are you doing in that other 99% of the week is really going to matter a lot if and you really need to focus on that. But with movement, we're thinking about the activities that people start. They say that you don't stop moving because you get old. You get old because you stop moving. And so we see this typical decline. And one of the biggest things is once you lose, quad strength in particular has been is a direct predictor of morbidity down in life, because as you start losing your quad strength, you start losing the ability to move. Specifically, once I sit down, I can't get back up again, And I noticed this with my my late grandparents, my grandmother. I could watch she get to the point where she couldn't get up on her own anymore. And then when you can't do that, you're not going to get up and walk around. So now you become less active as your body gets used more. Then it just deteriorates. That's a natural progression. So, we want to move our bodies and use them so that they stay healthier longer. And so a big thing is, you know, quad strength, quad motion, squatting, because that's just such a functional movement, going to the bathroom, getting in and out of bed, up and down from chairs, into the cars. When you lose that function, you lose your independence, you lose your ability to move. And so we focus a lot on squats, getting that full, your knee gets very stiff. And so sometimes you don't get that full extension when you can't fully lock out your knee, but you really need that to have a good gait where you're not using lots of energy. So we really focus on getting that end range extension, being able to get good, squatting motions, getting that quad engaged, getting that quad muscle movement, getting the ankles to bend a little bit better, dorsiflexion, so that you can get a little bit more movement. There's stiffness in the calves, strengthening the hips, all of these things that really help the individual move. So that's one piece, but a lot of our patients would come in and warm up maybe on the stationary bike for 10, 15 minutes before we get into our manual therapy program. And then after the manual therapy, the exercise, and this is a very common thing that people would say is, I feel like I can do my exercises better after the manual therapy. So like, I feel like, my joints move a little bit better. I get more, it's almost like they get more out of the exercise, when it's done in conjunction with the manual therapy intervention. So I would say there's lots of different exercises. There's probably not like, this is the right one. But if you can just get moving, people get into the pool. If you have access to a program like that, then that's great. If I try to get people in low impact things at home, like or at the gym, elliptical machines, or even just walking on the treadmill. There's a couple systematic reviews that even show that running doesn't make doesn't lead to increased degeneration or symptoms. And so now, if patients haven't been runners, just like with anything, I'm not recommending that they go out and run, but I have patients that are runners. They love to run and they don't even have a lot of symptoms, but now they're like scared to continue running. And with them, I share with them the evidence and say, listen, you're a runner, you love to run. There might even be a protective effect of running if you run. From the limited evidence that we have, that long distance runners maybe even have a protective effect. And so, man, I'm not going to stop you from running. And I don't think that's the health effects that you're getting from that are so good for you. Keep up with that running. You're doing what you're doing. But we've got to get more than what's the right exercise is coming into the space with the patient and figuring out what can work for them, because everyone's a little bit different. Everyone's at a different level. And so to change that behavior, we have to figure out like what works with them, what works in their setting, what are their barriers, what are their restrictions, and then work through those, because patients will come up with those. And that's where you use, things like our health coaches use motivational interviewing to try to really get at that problem, is to figure out, okay, here's your perception of why you can't do these exercises. Let's break that down a little bit and figure out how we can get to a point where you can do them. And that might be just as important as the types of exercises or the prescription, is like figuring out what exactly they can do and starting with that and working with that.
Yeah, I agree with you. And, we're so fortunate here at our university to make sure, and I know a lot of other universities are doing this too, Dan, but incorporating motivational interviewing in their process of education now. I know when I went to school, 20 years ago, I didn't get any motivational interviewing. I sure know how to do some really good therapeutic exercises as well as manual therapy, which is great. But now, to see the curriculum change, to understand that it is a behavior change and that our communication skills do matter with our technical skills. And I think that's really been fantastic to watch. I also love the fact that you shared with just how you really need to get meet the patient where they're at. I think that's a huge reason why people should consider coming to physical therapy, is to make sure that they're being met where they're at. The other thing too is I think about people who might get sore and get DOMS, which delay onset of muscle soreness, or even a flare up. right? And knowing that they have a physical therapist who they're seeing, who understand that and can help them work through that. I think those are all real important reasons to actually see a physical therapist. So, those are all things when people ask me, like my neighbors, I recommend it for those things, and I explain why, and that my hope is that they will learn how to exercise. That's important to them, right? And that they don't just do that. Yeah, go ahead.
Yeah, no, I was going to say that's a great point. I've met people that have had bad experiences with physical therapy, and I would say, if you have had a bad experience, or this is what happens commonly, someone exercises and they haven't exercised in a long time, and all of a sudden they get really motivated. They watch Chariots of Fire. I don't know, whatever. They're like, all right, I'm going to change my life.
Right.
I'm going to, and they haven't in a long time. So they go out and they do something that they remember they were able to do 10 years ago. And then they come back and they're really sore. Maybe they injure themselves a little bit. And so the connection that they make is, I went out there, I tried this, and it got worse. Exercise must not be right for me. Because I've had patients tell me like, no, I can't do exercise. Exercise isn't right for me. And that's just simply not true, because exercise exists on a huge spectrum of very, very intense to very, very minimal. There is some sort of exercise that everyone can do. And so if you've heard me speak on this before, the analogy that I always use is just, it's simple to, let's say you're taking antibiotics and you have an infection, right? If you know that, we know that antibiotics works for the right types of infections. It's really, really powerful. But if you take too little of a dose, it's not going to do what it's intended to do. And so you only take the partial dose, then you make it resistant, and it maybe doesn't kill, it doesn't kill the infection. And if you take too much, if you just are like, I'm just going to take a whole bunch of this, like you can get really, really sick because it becomes toxic. But nobody says, well, antibiotics are no good because they didn't help me. It's all about the dose. The dose is what matters and makes all the difference. And it's the same thing with exercise. If I underdose and take too little, I'm not going to get the therapeutic effects, and I'm going to think, oh, you know what? This doesn't work. And if I try to go out and do too much and I get injured and hurt, I'm also going to think, oh, exercise doesn't work. And this is where I think, a good physical therapist can help you get the dosing just right, and make sure that you're not doing too little, so that you don't have the right therapeutic effect. You haven't met that threshold where you're actually getting benefit, and also that you don't do too much because you're, really zealous and you're ready to change the world, and they want to get you there eventually, but let's work up to it. And so I think dosing is incredibly important, and that's where a trained a professional can really, really help you get that dosing right and make sure it's really effective.
Yeah, I like that a lot. And I think sometimes our dosing is very equivalent to pacing, right? I mean, I think that's maybe it might be a little different, but I try to think about that, like, dose it, but also seeing the pace of like how a person wants to be. And I think that's always, very interesting to me about, the trajectory of things. And that's why, honestly, I keep going back to the article. I just love the trajectory of the two different interventions. And I think one was, I definitely thought for sure the pain would reduce in the injections. I did, and I thought for sure that the PT would be sore, especially in the first 4 weeks. And when I saw it equaled the same, I was very surprised by that. But, that's the information. I guess the last thing I want to ask you is, you guys followed the study for a year. And can you maybe, I know you kind of already done it, but maybe kind of summarize like what you saw after a year?
Yeah. So, you do have some crossover. You have patients that, had multiple injections. I think at the end of the year, we didn't really have exit interviews or anything like that. But in both groups, the pain and function improved. And then it's at 4 weeks, and then it stayed about the same. It never got back to the levels that it was at the beginning. But the group that had the physical therapy, was just substantially better in terms of the amount of pain that they had improved and the amount of physical function. And so it's interesting. It's interesting to share these results with the physicians and ask them their thoughts, and does this help or change or influence your thoughts about how you're going to maybe recommend these interventions to because that's the other part too, to changing practice has so many moving parts. How do we take these results and disseminate them and have engaging conversations with everybody that's in the healthcare system to kind of understand this model, and to ensure that patients are getting good physical therapy. If you went out and had 2 sessions and somebody did a bunch of cupping or something on your knee, you came back and said, hey, physical therapy failed, it didn't work. Our physicians, our surgeons stepping in and saying, hey, I know that you failed PT, but what did you actually do in PT? What did you guys work on? And then if it doesn't meet the bar for quality physical therapy, maybe push back and say, no, let's wait until you've actually had a good course of physical therapy. So I don't know, other than what was in the paper, we saw those changes. Those are things that I'm interested in. We didn't have the ability, we didn't have any exit interviews, just conversations, here or there with physicians and surgeons that were interested. A lot of them were really, really surprised at the data. That's probably the biggest thing. Most of them were so surprised at the data that shows that most patients only get one or the other, and that such few people get PT. And so I don't know if maybe patients say that they got PT because they just did some exercise and went to the gym, and then when the doctors hear that, they're like, okay, and they kind of check the box and they think PT has been done, and so they move on. I don't know what explains the discrepancy between what they believe is a lot of people go to PT, and then the data shows that very few people go to PT. So it's really interesting, but hopefully, these things don't change overnight. Hopefully it's just another step, on the ladder, helping us get up there to improve overall care for everybody.
Yeah, and I think another thing too is like the fact that it was published in a journal that wasn't a physical therapy journal. I really felt like that was really powerful, Dan. I'm not, that's one of the reasons why I asked you to come on. Beyond it being a prestigious, probably the most prestigious journal, I just love the fact that you're always looking to publish on a non-PT journal, not because you're not pro physical therapy, because I know you do a lot for the profession, but I also know that you're really a researcher that's looking for, the research rigor, and you're publishing at the highest level. And the fact that it was in New England Journal of Medicine, I've had more conversations about that piece with other providers who are, primary care providers, orthopedists, and PM&R about that journal article than probably any other journal article that I can think of to date. And so I just want you to know, I think one of the things is also visibility about and rigor about it, about what we're doing and the experiments or the research projects we're doing. And I just felt like it was, again, I think a lot of the thing I've heard back too was they thought they were referring a lot more to physical therapy, number one. And then they really were surprised with the WOMAC scores and the differences that they saw. The other thing that's come up that you've already brought up that I'd like to maybe talk about before we close is the cost. Because a lot of people think that physical therapy would be more expensive. But when I looked at the cost analysis in the paper, it looked like it was very, very similar. And it looks like you look deeper into it in your other article. And we'll put all these links for the articles in the YouTube so that people who are interested in reading articles, which I love to do. Talk about, that's one of my to-do things is to read articles. We'll make sure we put those 2 links for those papers, but maybe talk about the cost, right? I know you did, but I just want to make sure that we were clear about that, because most people would definitely think that the PT would probably be more costly, but in the paper it says it was about the same. So is that true? Yeah.
And appreciate all the kudos and, all of that. But these things, I'd be remiss without saying that these things never happen, in silos and isolation. And like my team of co-authors and Gail Dial, the lead author on the New England Journal of Medicine one, who's been a mentor for a long time. They all played such a huge role in their vision, to see this through. So this definitely was a team effort and should be acknowledged. But in terms of the cost, so the thing is, if we didn't just look at the cost of the how much does the one injection for the intervention in the trial cost, and how much does these 8 sessions of PT cost. We looked at all knee-related care in the following year. So anytime you went back to see a doctor or anybody for knee-related care, we could track that in our health system, and there's a cost associated with that. So we really wanted to know over the course of a year, all of the medical care that you're seeking for your knee, is the cost of that care higher, lower, different in one group versus the other? And so those costs were the same in both groups, even though the injection was a little bit higher. And that's probably because in the injection group, that's where all the surgeries happen. So that does inflate the cost a little bit, but you can't remove those people because that's really that's a potential consequence of, heading down the route. And the fact that nobody in the PT arm had any surgery is really interesting. And the fact that they had additional visits for additional injections. So as you can see, and a lot of those ended up going to PT outside the study. They were kind of referred because we didn't stop that referral process. So, you might think I'm just getting this injection and then I'm done. But really what it turns into is I'm coming back for more visits. I'm coming back for more injections. Maybe eventually I'll get referred to PT anyways. I might have a surgery. And so it's not as clean as it might seem to you when it's being posed as an option in the some people it is. Some people get injections and they're good, but there's a lot of people or they're good for a while. I know a lot of people that were like, man, that was great. But then, 6 months later, I need another one. Or some people that say, man, the first two were great, but then I've gone back for like 3 more, but none of them have gave me that relief that I got with that first one. They just don't do anything anymore for whatever reason. So again, they work for some people. I think it's some great immediate pain relief in some individuals, but I think that when it comes at the expense of I'm going to do this and not exercise, or I can, it's a quick fix, you're just pushing the goalpost down the road a little bit further. And we need to have those conversations with our patients about what do you need to do here? Or what do you want to do? What's the long-term picture here for you? Like, let's come up with something that works in the long term and keeps you going instead of only something that works right now. So yeah, cost-wise, it was to the health system, at least, it was no greater cost to the insurance payers and to the health system, regardless of which route you went at the end of the year.
That's great. Yeah, I like that goalpost being pushed away or pushed downstream more. And I'm hoping that that this, the information that we're receiving will allow people to have more opportunities to try physical therapy. I think that's one of the things why primary care physical therapy, ED physical therapy, all of these other maybe different ways to get physical therapy is important. But I'm hoping that this will also open up those states who don't have direct access, or if you do, to get the more than the word out, because I want it more to be a word than actually the information. I mean, it's real information. It's not just, something that it was just, some expert opinion, right? It's a research that's been shown. And so my hope is that it will give people different options to try physical therapy for knee osteoarthritis to see if it could be beneficial for them. So with that said, is there any other things, Dan, that you think that maybe we want to say before we close today? I always like to give this to my guests because I know there's a lot that's been said today. And I really also appreciated you giving the credit to your team and other co-authors on the paper. I think that just shows not just humility, but the truth of like how much work it is, but also the power of working together on a project. So I also want to acknowledge that with your co-authors and your team, to thank them for their hard work and their just continue passion for this topic and other topics that I know you're researching. So, any last summaries?
Thank you. No, I appreciate the opportunity to get, this information out there. I would tell, physical therapists out there that, read up on this evidence, learn these skills, try to apply them, implement them in your practice. I would tell the referral sources and primary care providers to really think about, the strength of these findings and what kind of conversations they can have about referring patients to physical therapy, and to be mindful of the type of physical therapy that patients are getting to make sure that it's good quality physical therapy. And then I would, tell patients that, man, it's hard. It is hard out there. It's confusing. There's lots of information that's coming to you from all different directions, but, look for different sources. If you hear one thing, maybe get a second opinion. Man, we really want to make things, patients, that they're our family members, our friends, our neighbors. We have lots of people that we just, we really want the best for them. And I think there's a lot of really good stuff out there for you, and a lot of good to offer. You just have to look around, be interested, and also be willing to put in maybe a little bit of the work that's required to get to that point. But I think it's possible for a lot of people.
Well, thank you so much for your time, and thanks for joining us today.
Yeah, thanks, Dan.
This has been a production of George Fox Digital. If you like what you're hearing, subscribe to George Fox Talks on Apple, Spotify, or whatever you're streaming on. Check us out on the web at georgefox.edu/talks, where we have videos, publications, and more. And we're also on YouTube at youtube.com/GeorgeFoxTalks.